such as in Singapore, but scaling those from a single island country to an entire nation as big as the United States is much harder. That being said, I think that while we always reach for international comparisons in healthcare, in part because the US is such an outlier, it's helpful to remember that we have 50 states that are their own laboratories for healthcare reform, in large part because of the Medicaid program, which is administered on a state-by-state basis. And there's a joke among policymakers that if you know one Medicaid program, you only know one Medicaid program because they're all so different. I think North Carolina, where I spent several years, is a great example of this, where they worked over many years to now successfully expand Medicaid is a recent thing that's been going on, but more importantly, not just increasing access to health insurance, but transforming payment for health insurance, creating actually a fee schedule for these so-called social determinants or upstream drivers of health. It's kind of like putting where your money where your mouth is. If you want to talk about equity, if you want to talk about investing in things like housing and food, you can put dollar values in them and then try to allocate those resources to help people where they are. So hopefully those are some illustrative examples.
Yes, thank you so much. And I see that our audience question and answer box is starting to fill up, so I'm going to turn to that. The first one is also for Dr. Ford. Kayla Jones asks, what are some examples that have been done successfully to redistribute power by collaboratives and coalitions, or by government as well, if you have time?
Yeah, I mean, I want to start, first of all, thank you for this question. And it's a hard one to answer. I'll start with government because unfortunately, there are fewer, at least like sort of documented, easy to find successful examples. But one example that we actually talk about in the paper is a Washington State example. So in 2022, they passed a bill aimed at increasing participation of folks with lived experience on boards, commissions, councils, committees, and other groups like that by allowing low-income folks in the state and other underrepresented community members to be compensated for their participation. So the bill included a stipend up to $200 a day to cover, as well, in addition to expenses to cover travel, lodging, child or elder care, right? Because ultimately, when it comes to advocacy for a particular issue area, you might be asking a low-income person to incur the cost of potentially time off work, might be uncompensated, right? Like travel to the location, whatever sort of care responsibilities that person might have had. Like there's so many costs involved in even participating in these participatory governance processes that this bill tries to help address. So that's a successful state level example. And then I think the initial part of the question was more so about like community-based examples, like in collaborative and coalition-based examples. And I think that's another one that is kind of hard because there's just so much happening like all over the nation, right? Like Kushal said, like we got these 50 states, and within all of these states, we've got all these different localities, we've got distinct issues. Although a lot of issues tend to be interrelated, we've got distinct issues and distinct dynamics that are operating in all of these different places. And so we don't always see the like success stories like reported out in like the literature or things like that. But one example that I can share just from being here in Chicago and knowing some of the players here is, when COVID-19 was here, well, it's here, but for the initial response to COVID-19 in Chicago, we saw a partnership between local health departments, between local community engaged researchers who were connected to citizen scientists, and they were doing this work of sort of like disseminating hyper-local like health information and getting folks connected to the different resources. So to the point that some of the other panelists brought up about, specifically Joshua brought up about just the lack of a public health preparedness system. Like they came together as a real-time intervention to help to build that public health capacity. So I would say that is a successful example, but the examples in that way, I would say that they probably abound, but it's harder to find sort of like an aggregated list of like all of the ways that coming together have worked. But thank you for that question.
Thank you for that response. That was great. Moving to another question, which I think Dr. Sharfstein or Dr. Stanji might be well positioned to answer. The question is, studies of the impact of medical care on population health in the US showed effects at most 10% of health outcomes. Do we want health or healthcare?
I want health. That's my answer. And I think, to the extent our paper talks about it, it's about health, not healthcare.
And we have disproportionate investment. I mean, the earlier question about countries that get it right. One thing I think we can take from other countries is that other countries that do invest in some of the kind of more of the social and environmental contributors to health than on healthcare that's so far downstream. So we really do have the balance wrong. And within healthcare, we need a greater investment in primary care, going from 6% to more like 12%. But then also we actually need to invest in the other things that are contributors to health beyond the downstream, the healthcare.
Sorry to ask a follow-up on that, but what are some of those other factors that we should be investing in before the downstream healthcare?
Well, we know that having equitable access to education is a huge contributor to health. That leads to a more equitable employment opportunities. It's not just the rich or the poor. I mean, the rich are clearly getting richer in our country, and that disadvantages everyone, including the rich. So education and what that has effect on equitable access to employment are important things. And then the environmental determinants of health, climate change, the things that we need to invest in that and make sure that when we're paying for things, we're really paying for the full cost, that it includes the environmental degradation.
Thank you. We have a question here for Dr. McGinty. Which government agencies do you believe should be financing and subsidizing the desperately needed group housing / supportive housing to meet the gap in the public health system?
Yeah, it's a great question and a timely one. I am by no means a housing expert, but I'll give you my 2 cents. I think in an ideal world, which is not the world we live in, so I'll give you the real world answer following my ideal world answer. But in an ideal world, we would have a strong authority through housing and urban development at the federal level that sort of flows down to state and local housing authorities, which is how the system is designed. That system is broken. It is very under-resourced. And so, ability for people to actually access housing through that infrastructure via vouchers or public housing or sort of other efforts to support housing is, people face really long waiting lists. It's not viable in many places. So there are some really interesting experiments happening in the Medicaid space. By experiment, I mean natural experiments that Kushal talked about a few minutes ago. We have, several states. California is the most recent to be considering it. Arizona has done it, that are using Medicaid dollars to pay for housing. That is not, and will never be, in my view, a comprehensive solution to our housing problem in the United States. It is one little corner of the problem, but a potentially important corner in that it's designed to provide housing for a discrete period of time, 6 months or so, to people who, in the absence of housing, are very likely to have dire health consequences, and potentially really high healthcare costs as a result of those consequences. So there's a cost case for states to consider this option. So, states are thinking about using Medicaid dollars, and in some cases trying out using Medicaid dollars for people who might be about to be discharged from the hospital and have nowhere to go. And of course, if they're discharged with nowhere to go, they're going to end up back in the hospital. Medicaid dollars to help people who are transitioning out of the carceral system and similarly have nowhere to go and have a lot of health needs that could be exacerbated very quickly. So keep an eye on what's happening in the Medicaid space. And, the reality is that we perhaps need things like these Medicaid experiences to plug holes, but in an ideal world, we need a robust system around housing and urban development that would fully fund efforts for the broader population as opposed to specific subsets.
Thank you so much. Moving to a question for Dr. Kadakia. This audience member asks about how various payment models might impact rural low-density populations. So much of modeling of financial models seems to have built into them a concept of market competition that simply doesn't apply in rural areas. Do we need different payment models for different populations?
This is an extremely important question, especially because we've really seen a hollowing out of the infrastructure for care delivery for rural populations with many, many hospital closures over the last 20 years. And managing both financial sustainability for those hospitals to be viable, but also sufficient resources for them to actually deliver the care that's needed for their populations outside the walls of the hospital is really challenging. I don't have a perfect solution here. I think this is a really open question for the field, but I think there are a couple of experiments that can give us some insights. Number one experiment that happened in the last decade of payment reform was called the ACO investment model, or AIM, where as part of Medicare's larger efforts to create these value-based payment models, they developed a special one for providers in rural populations and serving other select populations, where they gave them some upfront capital to help them transition to these new payment models. Because part of moving towards a new version of reimbursement is also helping practices develop all the back-end capabilities to be able to do the data sharing, the care coordination. And that is actually one of the few models that ended up proving that it could save money, although it wasn't extended. I think is an example of how if we move towards these populations, there has to be resources and technical support to help them make the transition. Number two is an ongoing development in Pennsylvania, where Pennsylvania is adopting what's called a global budget model for rural hospitals. Global budgets are best known actually for their experience in Maryland, in which case there is a global cap that's set for hospital budgets across the state. And it's an attempt to kind of set payments, and Maryland has achieved nearly $1 billion of savings, in large part thanks to Dr. Sharfstein's leadership when he was the secretary there as well. And so while the results of the Pennsylvania model are ongoing, it's been complicated because of the COVID pandemic, I think that could be an example for rural populations. And the last thing I'd point out is that at the federal level, CMS is attempting to create new payment models for rural populations. They announced one called CHART, but actually this model, I believe, is ending prematurely because they've had some difficulties with stakeholders. So all of this to say is that there are many different options that are at the top of different folks' minds, but it shows there are challenges based on the type of provider, whether it's a community practice or hospital. It shows there are challenges based on the type of payer. It also shows there are challenges just aligning the incentives of stakeholders, because it's a really important resource for those communities, but getting it right is really, really challenging.
To piggyback on that, I'm reminded of what you said in your talk, Dr. Sharfstein, about how special populations actually was about half of the population in this report that you cited. How can we do a better job as a public health system of thinking about the wide swath of needs that we have in our population, rather than creating solutions that might serve one very specific group?
Well, I would say that rather than having equity be like this last detail in the application with, mentioning more than half the population, equity really has to be at the center of key issues for public health departments. And it's going to look different in different communities, what that means. In a rural community, it's going to look different than perhaps an urban community. But the idea is that we have a core function of public health is to make sure that everyone benefits from access to health, and that there aren't unequal distribution of health harms, and that means really thinking about that pretty early on as an integral component of key initiatives. And that means having these systems and staff and connections with community organizations and nonprofit organizations and businesses to be able to accomplish that. And so in public health, we don't want to dial it back to 2019 and just keep going. Public health has to look different, feel different, be funded differently, accomplish things differently. That's really, I think, a common theme across all of our presentations, that, this is a moment, thanks to the Milbank Quarterly, to, envision a different way of doing things. And for public health, there's not a simple answer to your question, but I think it's that question has to be asked in the right way by the right people, in collaboration with their community, around all the issues that exist today that the nation's struggling with, as well as for emergency preparedness.
Thank you. We just got a question that I think all of you will probably want a chance to answer. So maybe we can do like a quick lightning round situation. The question is, addressing which single hurdle or issue would be most impactful for population health in the next 5 years? It's a big question. Let's see. I'll throw Dr. Stanji under the bus first. We can start with you.
I think anything we can do to foster recognition of our common humanity would be helpful. So, we just had a National Academy of Science, Education, and Medicine report on implementing high-quality primary care, and they call it a common good. And I think the reason is that it's a way of understanding people as individuals and not putting them just into groups. And I think that's how we need to approach things in public health and in healthcare. So how can we support people that are working at the scale of the personal, where people get to know each other, recognize each other as people, and then we can scale up to working on some of the larger problems. So supporting people on the front lines.
Thank you. Dr. Katakia, would you like to go next?
I would say it's moving towards universal coverage for Americans. I mean, there are tens of millions of folks who still do not have access to health insurance. And so much of our paper that we wrote on payment reform is predicated on the idea that there's someone still paying the claim. And part of the reasons that costs are still a big problem is because no one else has them as an insurer to defray them. And, the ACA was a tremendous revolution in increasing access to care. But with tens of millions of Americans still lacking health insurance, and I think the current unwinding of Medicaid rolls after the public health emergency is just a timely reminder that this is still a gap that many, many people fall through. And it affects people at all stages of life, from childbirth all the way until old age.
Thank you. Dr. Ford, anything you'd like to add?
First of all, I love these answers. I would like to say history, education. I think it feels critical to come to as much of a shared understanding of the systems and structures and policies that led us to our current place as possible, so that we can begin to move forward together, or as much of together as possible.
Thank you. I think we just have a couple minutes left, but I do want to get to Dr. McGinty and Dr. Sharfstein. So if you have any lightning fast thoughts to add, please do so.
I think we should prioritize continuing some of the social safety net expansions that happened under the COVID-19 pandemic, particularly child tax credit expansions and unemployment insurance expansions, which are key contributors to reducing poverty that underlies so many of our health problems in the US.
Yeah. I just say I'd like to see health moved out of the political fray a little bit. I think when we're in such a politicized world, it is very, very hard to make progress in the United States. And it's just very unfortunate that some really core issues for health have become so politicized. And if we could somehow unwind that, or, stop the forces that are winding it up tighter, like misinformation, then I think all of the efforts that we're talking about would be easier.
Thank you all. This has been such a wonderful discussion. I've really enjoyed moderating it and hearing all of your ideas. And with that, I will turn it back to Dean Galea for some closing remarks.
Well, thank you, Jamie, and really thank you to all our panelists. As Dr. Cohen mentioned at the beginning, I've had the privilege of working with a special issue and reading all these papers, but I learned very new things in listening to you all, both in your presentations and in the conversation. So thank you for being a part of this. Thank you for everything that you do. I want to say thank the audience for a really engaged audience, excellent questions and excellent comments. And for everybody who's interested, we have a panel 2 tomorrow and then panel 3 the day after. Everybody, thank you for being a part of